Okay, so good morning. This morning is one of our MSERS multi-subspecialty education for low resource settings part of the series that we are very grateful to have assistance in putting out to you each month. This morning we have our approach to diarrhea for remote and remote settings. So maybe I will let you introduce yourself and we will go from there.
Sounds good. Thank you so much for having me. The audio on my end was a little bit cutting in and out, so hopefully the connection stays okay. If there's any issues with the connection, or feel free to let me know. I could go off camera, and as long as the audio works, I guess. Um, so my name is Yipeng G. I'm a family doctor based in Ottawa, but and that's also where I'm calling in from. I'm calling in from the traditional unceded, unsurrendered territory of the Algonquin Anishinaabe. And I have worked in various settings throughout my medical training, including in Iqaluit, in Nunavut, in some of the nursing stations. I don't think they're called that anymore, but it's like the kind of like primary care locations where patients kind of access, where there's usually just a nurse, and sometimes, if we're lucky, there is a nurse practitioner, and and a lot of things are reviewed over the phone with a physician who is hundreds of kilometers away. And so I really appreciate all the work that you do in Northern Ontario in low resource settings. Recognizing that there's obviously much more improvements needed at a structural and systems level. Um, but we continue to try to do what we can within the existing systems that we have, I suppose. Um, the topic that we'll go into today is a fun one, is diarrhea, I guess. And we'll go through an approach. And here are some of the learning objectives I put together. To review a general approach to diarrhea, acute and chronic, and to understand key features on history and physical, as well as a volume and hydration status exam. Review the red flags for diarrhea that may warrant more urgent investigation management, and review briefly the role of investigations and treatment for diarrhea in a low resource setting. And if there's any kind of questions at any point, feel free to drop them in the chat. I believe I can see that. Just have it on the side in case you have questions at any point, and I'll do my best to answer them throughout the presentation. So I thought it'd be good to start off with, a definition of what diarrhea is. I think patients might come in with varying degrees of what loose stool or diarrhea might be. And I don't actually commonly think of the definition but anyways, here it is. Acute diarrhea being over 3 stools a day or over 200 grams of stool per day for 2 to 14 days, and stools are looser and more frequent. I think stools being looser and more frequent is one of the biggest things that patients usually notice and might present with the main complaint of diarrhea. But otherwise, I think just keeping in mind acute diarrhea kind of around the 2-week mark is a good rule of thumb. And then the definition for chronic diarrhea is over 4 weeks in length. I've had a handful of patients where diarrhea for like a long period of time, like certainly over 4 weeks, is something that they've kind of constantly struggled with the patient, but sometimes there's something more underlying, and you actually and it's quite treatable as well, depending on the underlying condition. You might have already come across the Bristol stool form scale, so it's just a good reference to go back to when patients are just trying to describe to you what their poop looks like. Sometimes it's not the most photos. Sometimes they have photos related to blood in the stool, and it just kind of helps to get a picture of like how much blood really was it. What does the form of the stool look like? So you see here the stool from type 1 to 7, from like a very dehydrated kind of picture, very like hard stool being type 1, and then a very, very loose or like watery stool being type 7. So a good general approach, I think like really there's so much that you can do prior to even the physical exam. So taking a really detailed history to kind of get an understanding of the amount of stool, the quality of the stool, really kind of getting a picture of the last slide that we kind of reviewed, the volume, the frequency, any urgency that they might have, and then thinking beyond just the diarrhea symptoms of things like fever, abdominal pain, nausea, vomiting, weight loss. Now moving to other kinds of like viral respiratory symptoms, so like cough, sore throat, arthralgias, myalgias, so like joint pain, muscle pain. And now we're thinking more systemically infectious, systemically inflammatory, and then also diet and symptoms associated with food intake, because we know stool is made up of digested food, and so when there's certain kinds of food intolerances or certain kind of conditions where we might not have, might be having like an immune reaction to something like gluten, for example, then you might have, um, uh, this diarrheal picture. And there's also certain kinds of foods to avoid if you have like irritable bowel syndrome. So some people also do play around with their diet to try to manage their symptoms before coming to seek medical advice and attention. Do a good medication review. Some patients are not on
Okay, we'll just give him a moment. Welcome back.
Thank you. Sorry about that. I think my internet has been unstable this morning, so I actually just reconnected to my phone and I'm hotspotting. So um the challenges of technology. Should I just go back to where I left off?
Yeah, that would be great.
Sounds good. All right. Um, so did I leave off like where I cut off? Was it like just talking about the travel history review?
Yes. Yeah.
Okay, thank you. All right. So, yeah, in addition to travel, like just any kind of like new water source for consumption, because um, depending on the communities that you're serving and you're looking after, caring for, like the water source might itself be contaminated and might not be a good water source for drinking water or for cooking, sometimes even like bathing and showering as well. Um, uh, as well, review if there's any kind of like food related outbreaks. If you're seeing a pattern with like multiple patients related to, let's say, a certain kind of like workplace, but more typically like a school setting, as you might see multiple kind of cases related to like diarrheal illness, if there's a food related outbreak. And there might be public health alerts out, depending on if someone else has already caught up to something like that. And also just getting a sense of if there's anyone else sick, and certainly a recent hospitalization could put you at risk for other kinds of infectious diseases that also cause diarrhea as a symptom. Um, uh, and kind of similar to that, recent hospitalization, I also think of recent antibiotics as well. I should have put that in the previous bullet point. Um, Past medical history review. So have they had, the symptom before, like, and to this kind of similar degree, any previous gastrointestinal related diagnoses, any inflammatory or autoimmune diagnoses, any thyroid related diagnoses, any cancer diagnoses. These things are some of the top of mind related to diarrheal presentations if outside of like the kind of a more typical infectious diarrhea picture. A family medical history review as well. So just similar kind of questions. If there's any diagnoses of those things within the family. And so moving on to the physical exam, uh, quite typically actually the first thing that we kind of do with a physical exam is we don't even examine the patient. We just kind of look at them and see if they are kind of sick or not sick, well or unwell. So, and kind of over your time caring for many patients, you probably also have this kind of gut feelings already, where you might meet a patient and you just kind of know that you're worried about them. You're worried that there's just something more sinister going on, or you're worried about them decompensating and getting worse really quickly. So trust that gut feeling, and make note of that and share that with a physician or someone else who you might be reviewing the case with later on. But then, of course, when you're doing your normal vitals, and including, the temperature and the respiratory rate. These are, and the SpO2, like the oxygen saturation, like these are really important. But more specifically related to diarrhea, when we're thinking about volume status, is getting an orthostatic vitals done. So you could get the patient's vitals done with them sitting down, which is the most typical readings that we get done. And then you also get them done standing up. And then if you want to really compare, you could do them lying down to sitting up to standing up. So three readings. And a positive kind of orthostatic vital shift or change is that you notice that they have an increase in heart rate of 30 points from going from sitting to standing, or their systolic blood pressure goes up by 20 points from sitting to standing, or their diastolic uh, blood pressure, sorry, if their systolic blood pressure drops by 20 points, and then if their diastolic blood pressure drops by 10 points from sitting to standing. So, yeah, if the way it makes sense in my mind is the body is trying to compensate with the heart rate going up from just making sure the blood keeps flowing where it needs to go when you're dehydrated. So that's why the heart rate will go up over 30 points from sitting to standing. But then the blood pressure struggles to compensate, and so you see that decrease. And so from sitting to standing, you have a drop over 20 points with systolic blood pressure, or over 10 points with the diastolic blood pressure. So any of those criteria are met, then you have a positive orthostatic vital change. And then, of course, even if they're just like sitting and they're tachycardic, their heart rate is over 100, you do wonder about just some degree of dehydration or some kind of infectious process going on, or some degree of stress as well. So a more comprehensive volume status exam, is you can look at the jugular venous pressure, or JVP. I've always had difficulty looking at this, but this is just looking at the internal, jugular vein and seeing if it is below where you might expect it when you're examining the patient. And decreased skin turgor. This is kind of seeing how quickly the skin kind of like rebounds when you pinch the skin. And you can do this, uh, depending on the age of the patient. You can do it on, usually for an adult, you can do it on their hands. And for a child, you could, really do it somewhere else as well. A delayed capillary refill. This is just taking a look at their fingernails and seeing how quickly the blood rushes back into the fingernail after you press down for a couple of seconds. And if it's delayed like more than a good couple of seconds, then you wonder about dehydration. Dry mucous membrane, so you look inside the mouth to see if they're well hydrated. And particularly with a pediatric patient, you would want to look at their tearing and seeing if they are producing tears, especially if they're irritable on exams. Sometimes you may or may not see tears. And you want to also check if their fontanelle is open. You can check if it's sunken. That is also a sign for dehydration. And certainly for any age, but in particularly for pediatric patients, is decreased urine output. So I'm asking about those wet diapers if they're not potty trained, and then if they are, it sometimes is a little bit more challenging to kind of get a sense of urine output from a parent, but sometimes the child can also tell you that they just have been going to the washroom less frequently. And sometimes hypovolemia, like decreased volume status, is good to kind of put in these boxes of mild, moderate, severe. And then abdomen, just to kind of see if there's any bowel sounds present, and you can palpate and see if there's any areas of specific discomfort or any masses. Do if appropriate, especially in like older patients where you might worry about a mass, like a colon cancer or prostate cancer, then doing a digital rectal exam is certainly part of the physical exam. Or if there's blood in the mixed with the stool or on wiping, it's usually quite helpful to do a digital rectal exam to see where that bleeding might be coming from, if even able to kind of visualize it very briefly on a digital rectal exam. So I thought we would jump into a few cases with that kind of background knowledge now. We'll go into a few that hopefully can help you kind of like think through some of the possible diagnoses. I've put together a pediatric, young adult, adult, and an older adult case. And these are not real patients. I just kind of made everything up. And the photos are from Google Images, stock photos. So here's a 2-year-old girl. She presents with diarrhea. And the history is that she's here with her mom with this 4-day history of diarrhea, decreased oral intake with nausea and vomiting, has been attending a home daycare program. We're unsure about the sick contacts, about any sick contacts at the daycare. She's previously healthy. Her immunizations are up to date. We learn from her physical that she's got a fever, a temperature of 38. Her blood pressure is 90/60, which is, when we look at the reference ranges, is within normal for her age. And then her heart rate's 80, her respiratory rate is 25. And if we look at the normal resting respiratory rate for children her age, that is also normal for that age group. Her oxygen saturation is 99% on room air. And then her mucous membranes are dry, and we do notice some decreased tearing and some decreased urine output. So some of the possible diagnoses might be like your typical viral gastroenteritis because of the collection of symptoms, because of possible sick contacts at the daycare. More specifically, sometimes we see hepatitis A, which is a viral infection that causes a gastroenteritis picture, a kind of diarrheal picture, including nausea and vomiting, with fever. Sometimes on the physical exam, you might see things like jaundice, like yellowing of the skin, yellowing of the whites of the eyes, and it's a self-limited condition, and same with viral gastroenteritis in general, especially with such a short kind of uh, history and picture uh, of the diarrhea. The main thing is supportive management and just kind of making sure they are well hydrated, and just monitoring for that in case there's any kind of decompensation, and giving good kind of parameters for the patient's mom to kind of bring her back to be reassessed in case this doesn't get better within the next few days to a week or so. Um, I have a case here is a 20-year-old man who presents with diarrhea. There's a 7-day history of intermittent diarrhea. So pain with bowel movements. There's noticing some blood with bowel movements, sexually active with males and females, including receptive anal sex, family history of inflammatory bowel disease. Mother was diagnosed with this in her teenage years. So the physical shows a temperature of 37.6, blood pressure of 135/85, a heart rate of 100, a respiratory rate of 15, oxygen saturation 99% on room air, mucous membranes are moist, and normal urine output. So what kind of sticks out on this physical is quite honestly not much, except for the heart rate being elevated with tachycardia. One thing that I didn't put here is a digital rectal exam. So because of the history of blood in the stools, then certainly that would prompt a digital rectal exam in this case. So some of the possible diagnoses for this patient might be proctitis, like inflammation, in um, the last part of the large colon, or colitis, or a sexually transmitted infection, recognizing the history of receptive anal sex. So you wonder about chlamydia, gonorrhea causing this picture of inflammation to the last part of the colon, to the anal region, causing these symptoms. Or it could be bacterial gastroenteritis. As we know, there are certain kinds of bacteria that cause um, bloody diarrhea. And kind of the more broader kind of inflammatory colitis picture is something that we're also thinking about because of his young age and the positive family history. So that might warrant further discussion around specialized testing to kind of get a sense of uh, how much inflammation there might exist for the large colon if it extends even beyond that as well. Here's a case of a 35-year-old woman. She presents with diarrhea. Might be seeing a pattern now with what your patients are presenting with. She has a 6-week history of intermittent diarrhea. It was initially thought to be related to certain foods, but she attempted and changed said foods without good effect. She's not really sure what's going on. Sometimes she also has constipation. There's a family history of autoimmune conditions. So on her physical, she has a temperature of 36.5, blood pressure of 125/75, a heart rate of 95, a respiratory rate of 16, and her oxygen saturation is 99% on room air. Mucous membranes are moist and normal urine output. So nothing really kind of sticks out too much on this physical, but I would say there are other things that you can kind of check for this woman. If we just kind of go back here and the family history of autoimmune conditions, you might kind of wonder about a thyroid condition. So you could do a thyroid exam, see if there's any kind of other signs on physical exam that might suggest a more broader inflammatory picture, such as like an inflammatory arthritis picture. And but if it's really just limited to this symptom and complaint, then perhaps this physical is also sufficient. But some of the possible diagnoses might be hyperthyroidism. It could be a more inflammatory picture, like an inflammatory bowel disease that hasn't kind of been as overt as the last case that we saw with like blood in the bowel movements. It could be irritable bowel syndrome. Sorry, that's a typo. IBS. That is more of a combined picture of diarrhea and constipation, and is usually self-limited, usually like more brought on by stress. But I typically do think of it as like a diagnosis of exclusion, making sure that aren't these other more immediately treatable conditions that also can get worse if we don't identify them earlier. So kind of leaving it to the side and ruling out some of these more insidious, worrisome diagnoses like celiac, for example, or inflammatory bowel disease. And so getting a full picture around their dietary intake, what's worked well, what hasn't worked well in the past, getting a picture if they've ever kind of come off gluten and see if that's done anything. And if they are on gluten, then we can talk about that later on. That's like a good opportunity to actually do some testing for celiac disease. So the last case I have for you is an 80-year-old man. He presents also with diarrhea. He has a 2-day history of diarrhea, has been having fever and night sweats, blood with bowel movements, and there's a complicated past medical history with diabetes, high cholesterol, a prior stroke, and he's also been previously treated for prostate cancer, which is in remission. His physical exam shows a temperature of 37 degrees, blood pressure of 138 over 85, a heart rate of 90, a respiratory rate of 15, and an oxygen saturation of 99% on room air. Mucous membranes are moist and normal urine output. You do a digital rectal exam because of his past medical history of the prostate cancer, and you notice a tender, enlarged, irregular prostate. Um, but since you might have not seen this patient before, you're not actually sure what his baseline might be if these are chronic changes from his prostate cancer that has been told to you or reviewed on history that is in remission. But just kind of the overall picture, you quite kind of are quite worried probably about something more systemic, something more neoplastic, or like a cancer going on. Um, and so that's kind of like what we should be worrying about. But certainly a more like acute viral gastroenteritis picture certainly might be still part of that overall picture because of how suddenly the symptoms came on. Um, uh, so part of our role is to kind of think about what is most likely, but certainly what are the things that we don't want to miss. We want to keep an eye on just to um, uh, it is, and I guess from our point of view is thinking about the worst case scenario and making sure it's not that, or doing what we can to try to rule those things out through the history and the physical, and perhaps with investigations if appropriate. So some of the red flags to think about is like uh, like first presentation, like age over 50, or a pediatric patient with a worrisome volume status exam, and that's more so around the risk of them decompensating and doing and just needing some more monitoring and support so that they can get over what they might be might be having, which is usually more likely a kind of acute viral or bacterial picture. But just knowing that the volume status exam is um, quite important for children, quite important for older adults, but I would argue specifically for children because they're in a more vulnerable position where they might not be seeking out more fluids in the ways that adults are able to look after themselves. Um, on history, ensuring that we remember the constitutional symptoms to review, such as fever, night sweats, weight loss, that might kind of hint at something more sinister, something more systemic going on. Hematochezia, so blood, frank red blood in the stool. And I would probably also add digested blood, melena, so black tarry stool as well. Nausea, vomiting, arthritis, skin rash, anorexia. So once again, these things are telling us there's something more like comprehensive, something more affecting multiple systems that's going on, something maybe more inflammatory, affecting other bodily systems, other organ systems in the body, and nocturnal system symptoms as well. And on exam, postural lightheadedness, orthostatic vitals, which we talked about, tachycardia, and palpable mass on digital rectal exam. And so some of these things are really because the body is not really compensating well from the losses, the fluid losses from the diarrhea, and perhaps they need more monitoring, they need more supportive management, and just to ensure that they don't continuously lose more fluids than what they're able to put in. And sometimes you might need to support them with IV fluid hydration so that they not only feel better, but then also you don't have decompensation with affecting other bodily systems and how they're managing with dehydration. Here is an acronym, as I briefly alluded to earlier, about bloody diarrhea. And so um, uh, the mnemonic is sexy. So bloody diarrhea doesn't sound sexy. So S is salmonella, E for E. coli, E also for Entamoeba, C for Campylobacter, S for Shigella, and Y for Yersinia. And so these are all causes of infectious bloody diarrhea. So just know really that like bloody diarrhea is not great, and perhaps a sample can be taken so that we get a better picture of what kind of bacteria is causing it, or can start some empiric treatment as well, which I have on a later slide around treatment. A more comprehensive picture around like possible diagnoses for acute diarrhea um, uh, kind of can be categorized in a few different groups. So when we think about actually like a lot of these are all like quite infectious. So we have parasitic infections, we have bacterial infections, we have viral infections, travel-related infections, and daycare-acquired infections, and hospital-acquired infections. And then when we think about a more chronic picture of diarrhea, this is where we have more a mix of different kinds of pathologies. So functional, meaning like irritable bowel syndrome, actually accounts for 10 to 20% of chronic diarrhea. But once again, I do kind of like think of it as a diagnosis of exclusion unless you're quite certain and the patient actually has like talked to, let's say a few other doctors or other kinds of health professionals before and was thought to be irritable bowel syndrome and we're for sure that's what it is. Then you can kind of just manage the symptoms. But I try to leave it for a diagnosis of exclusion just to make sure we've kind of ruled out these other things. So while you're on certain osmotic agents, like things that pull water into the large colon, that's going to cause diarrhea because the large colon is supposed to absorb much of the water and the fluid content so that our stool is mostly solid or fully formed. Um, Inflammatory pictures, so like inflammatory bowel disease like ulcerative colitis and Crohn's disease, and other types of colitises. Metabolic, like hormonal imbalances that affect cortisol, that affect thyroid hormone. These are things that will affect how our body metabolizes and how it also once again can have enough time to whether it be time or the ability to kind of absorb all the nutrients and water in the large colon, leading to kind of dumping of the contents and it coming out as diarrhea. Cystic fibrosis is also here, and it's more so related to the ways in which some of the cilia, some of um, uh, the small membranes that are affected by cystic fibrosis, they don't work as well, and so you don't have good processing that actually allows for the stool to be fully formed, but can be treatable with enzymes. Maldigestion and malabsorption. And this is, there are certain kinds of things that the pancreas excretes, but also certain kinds of ways in which when you have something like celiac, you actually have like an autoimmune attack on parts of the gut that lead to an inability to kind of really process something like gluten for celiac disease. And so when you have maldigestion, malabsorption, once again you have issues with like fully forming that stool through different parts of the gut as the food goes through the stomach, the small intestines, large intestines. Neoplastic, so kind of a cancerous picture, um, uh, various kinds of cancers along the gastrointestinal tract, or like a thyroid carcinoma related to the ways in which our body can metabolize things. Um, so that's something to keep in mind. If there's a thyroid kind of picture that's contributing to the diarrhea. Iatrogenic, meaning caused by us, caused by healthcare. If it's related to drugs, alcohol, caffeine, surgery, radiation, laxative medication. Um, More briefly, some of the investigations that you can do in a more resource setting, or depending on if you have any of these possible investigations. You could do a complete blood cell count just to kind of get a sense if there's any blood losses, like through a low hemoglobin, if they've been losing a significant amount of blood, if you're worried about a bleed, or worried about blood in the stool. You could also see a white cell count, which might indicate more of an infectious process. Electrolytes, creatinine, urea, inflammatory markers like CRP, ESR, protein, albumin, blood gas to see how much they might be compensating for fluid and electrolyte losses from diarrhea. Um, I don't think it's called FOBT anymore because we have the FIT test, but essentially just a test to see if there's any blood in the stools that you might not see visually, and we might be more worried about something more insidious going on. And a scope if necessary. You could do an abdominal X-ray, abdominal CT scan to get a sense of any structural abnormalities. You could also see like fecal loading, like a fecal mass on an abdominal X-ray, and certainly with a CT scan, you have much better visualization of the soft tissues in general, and the multiple organs in the abdomen. Chronic diarrhea, you could do a fecal protectin, Giardia, celiac testing, bile acid testing. And it's actually recommended to not do ESR, CRP, and no stool, ova, and parasites if no travel and immigration history. Just to kind of see if there's any inflammatory picture with a fecal calprotectin, Giardia for infectious, and then celiac with an anti-TDG, for example, if they're already consuming and on gluten-containing foods to see if they might be diagnosable for celiac disease. And a TSH, a thyroid stimulating hormone, to kind of get a picture of if they have hyperthyroid or something more like a thyroid cancer, as mentioned before as well. So in terms of treatment, you want to treat the underlying cause if you know it, but much of the time we don't, and that's okay. So the main thing is the symptom of diarrhea is that you're losing a lot of fluid. The stool is not being fully formed in the large colon typically, and you're losing quite a bit of fluids, depending on how much diarrhea is happening. And so hydration is really important. So you replace with oral fluids if possible, and if by your exam or by history you're worried about the patient, then IV fluids might be necessary to replace their fluid losses, especially if you notice anything like the postural vitals, the orthostatic vital changes that we mentioned, or if you're quite worried about their fluid or volume status exam. There are specific treatments that you could be given for infectious diarrhea, such as like C. diff. You could treat with vancomycin, multiple bacterial bloody diarrheal pictures like Shigella, Salmonella, E. coli can be treated with ciprofloxacin. And then in the meantime, like you could talk about dietary changes if it feels appropriate, if it's less acute and less of an infectious picture. You could talk about dietary changes. There's something called a low FODMAP diet to switch the types of foods that patients might be eating so that it's a little bit more tolerable, especially if there's a concern for the diagnosis of irritable bowel syndrome. And then increasing dietary fiber, exercise, peppermint oil. These are all excellent things. If this is more of a chronic picture and less worrisome from a picture of cancer, less worrisome for pictures of inflammatory or something else more systemic. And of course, if you're quite worried about the patient because of your history, because of the physical, that or because of other comorbidities, if they're an older adult, if they're a really young child, certainly hospitalization and referral are part of that picture. This was the reference that I used, family medicine notes, and there's a few reference slides beyond this that I hope might be helpful for you. There's something called osmotic versus secretory diarrhea. If we can think about um, the pathology, the pathophysiology of like why diarrhea happens in the first place is like I mentioned, like usually like the large bowel is not absorbing all of the absorbing a lot of fluid and water out of our stool. Um, but when the diarrhea continues despite fasting, so despite us like not eating, despite your patient not eating, then there's still secretions going on. So it kind of goes into that category of secretory diarrhea. But if it decreases with fasting, then it's more so considered this osmotic picture where there's an issue with the water being the fluid being absorbed by the large colon, and you might think of it being more of a malabsorption issue, might be related to drugs. And these are some of the risk factors that we already talked about. Important to think about, once again, travel, immunosuppression, food outbreaks, history of antibiotic use, family history of similar laxative use. These are the differential diagnoses for acute and chronic diarrhea that we went over. We went over the red flags, and I think that's the end of what I have for you. Hopefully that was helpful. I would say, and you can have my slides to kind of review as well, but I would say the mainstays are really just looking at a comprehensive history and physical and thinking about how worried are you about this patient. And also getting a good volume and hydration status exam done because when these things are comprehensively done and reviewed with someone else, then it really gives them a picture of how sick the patient might be, how worried you might be about them, and knowing the ways in which we can present a case around acute versus chronic diarrhea and the things that we might be worried about, from an infectious, inflammatory picture to something that if we're not worried about all those things, then maybe it falls into that bucket of irritable bowel syndrome as a diagnosis of exclusion.
Thank you so much. Are there any questions? So I just want to thank you for the focus on, I think one of the things that we're learning from these MSERS presentations and the approaches to different sort of symptoms is the importance of a good history. I think that's what the last presenter highlighted as well, and just how crucial that is in, especially as nurses when you're working with a consultant potentially at a distance, right?
Mhm. Absolutely. I actually do a little bit of virtual care as well, and so when doing that, like I don't have the benefit of doing a physical exam and vitals whatsoever, and so um, doing what we can with a really detailed history is usually what actually gets us most of the towards a diagnosis or towards a differential diagnosis to kind of figure out a plan. Um, yeah, I would really put a lot of energy into getting that piece, and part of it is also like how concerned the patient is about the symptoms as well, right? And what brought them in today specifically for this. So sometimes patients are very worried about like colon cancer or not only because of a diarrheal picture, or maybe because they saw a little bit of blood in their stool, and so they're very worried about colon cancer. And so just having a conversation about that can really help settle some nerves if it is appropriate to kind of settle said nerves, but if it's more appropriate to kind of refer on, do more investigations, then that's also very reasonable as well. But getting a sense of how why the patient is presenting today in the ways that they are is really important. And I haven't done these presentations before for this group, so I'm happy to take any feedback that you might have and um, rejig things if I'm ever welcome back. Or yeah, I hope it was helpful, and I hope to make it more helpful in the future. Yeah.
Okay, one last request. Any questions? Any comments? Any feedback? So I see a question in the chat. I had to step away for a minute. Would you send stool cultures often?
Yeah, that's a great question. So I would say if, there is, a concern for like a bacterial um, diarrheal picture, like if there's acute bloody diarrhea, that would be a good reason to send stool cultures and also stool O1P. But for most cases of acute diarrhea, it's most likely viral. And so by the time you send stool cultures off and they come back, the patient might already have gotten better from their diarrhea. So I would say, if it is a younger patient, younger being like adolescents to under the age of 50, and there's no red flag symptoms, and there's no bloody diarrhea, you're probably okay with avoiding stool cultures. But if they kind of represent something's kind of grumbling along, then doing a more fulsome workup would probably be, yeah, most appropriate. Uh,
Okay, perfect.
Uh,
We'll take, oh,
Sorry, it's Marilyn without a voice. Dr. G, I wanted to thank you for commenting, and I apologize, I missed, maybe you've already emphasized this, the issue of bloody diarrhea and the association with colorectal cancer, and just highlighting the importance for follow-up, because we're seeing younger and younger people
mm,
with colorectal cancer, and just making sure that people know that if it doesn't resolve, that we sort of stay on top of the symptoms. Sometimes the history doesn't come out as crisply as we would like, and so just making sure that those connections are maintained with the patient to make sure that we don't miss something. We're seeing people in their 30s with this diagnosis now, and it's really worrisome. And so just wanted to emphasize that.
Yeah, that's a really great comment, Marilyn. Thank you. I think like any kind of like presentation of diarrhea, and then there's like any kind of like semblance of something not feeling right is just, uh, emphasizing the importance of appropriate follow-up. And like, a little bit of blood in the stool, um, might be something like a most benign thing, like hemorrhoids, for example. But we can't, yeah, we shouldn't normalize that, like it's not normal to have blood in your stool, right? So if that is something that is persisting, absolutely needs follow-up. And I've also heard this as well, where they're a bit anecdotal, but I think there's some good evolving epidemiological evidence around this as well, where there are just more and more young people being diagnosed with cancers at a younger age, including colorectal cancer. There's something going on, and so some of that can also send some flags off for more like systems and structural issues if there are worrisome like contaminants, for example, around some rural remote communities that might be tied to environmental racism, as we know exists for various remote rural Indigenous communities where they have higher incidences of certain kinds of cancers just because of the environments that they live around. So sometimes we have to think about the ways in which we do screening should be a little bit different as well, like just on history and physical and investigations.
Thank you.
perfect. Thank you so much, everybody. Um, Thank you to our presenter. Thank you to those who attended today. And if you're willing, we would love to have you back. So we look forward to interacting in the future. Thanks everybody for your time today.
Thanks for having me.